Hello everyone, I'm Dr. Gary Small. I'm a professor of psychiatry and aging at UCLA and director of the Division of Geriatric Psychiatry. And today we're going to be talking about early onset Alzheimer's disease, what families and patients need to know. If you have questions, go to Twitter and use the hashtag UCLAMDChat. Be happy to try to address some of those questions at the end of the presentation. Let me begin by just acknowledging the support for some of the research I'll be talking about, as well as potential conflicts of interest, and some of the collaborators who have worked on some of these studies. Now, we're talking about Alzheimer's disease today. The focus is going to be on early onset, but early onset shares many of the features of late onset. So some of my comments will address Alzheimer's disease in general. And whether you have onset early in life or late in life, it's clear that it's a concern on everybody's mind. We hear about it in the news every day. There are headlines that are often hard to sort out. There are celebrities who talk about their family members, celebrities who talk about their early diagnosis. Here I have an image of Pat Summitt, who passed away recently, and she had early onset Alzheimer's, which is pertinent to today's discussion. And when it affects people early in life or at any stage of life, it has a major impact. Now, why do we hear so much about it today versus earlier? One of the reasons is that we're living longer. Life expectancy at birth in 1900 was 47 years. Today, it's into the late 70s, early 80s. And age is the greatest single risk factor for developing Alzheimer's disease. We have nearly 80 million baby boomers who are reaching the age at risk. And one statistic is quite startling. Every 70 seconds or so, another American is diagnosed with the disease. And the cost is astronomical, over $200 billion a year just in this country. Let's begin by answering this question: what is Alzheimer's disease? Well, it began in 1906 when Alois Alzheimer described the first case of a woman who first became confused in her early 50s. And after 4 years, she died, and Professor Alzheimer did an autopsy and applied special stains to her brain. And you can see in this image the plaques and tangles, these little waxy protein deposits collected in the brain in areas that control memory and thinking. And that was the first defined case of Alzheimer's. Now, the medical community didn't take much note of it because this was a middle-aged woman. And the assumption was that Alzheimer's disease was a pre-senile dementia. It only affected people early in life and was relatively rare. However, in the late 1960s, pathologists studied what was then called senility, people older in life who became confused. And when they looked at their brain autopsies, they found the same plaques and tangles, which resulted in a lot of public fear and a concern about an epidemic of Alzheimer's. The upside of that is that it forced scientists and doctors to look at this more carefully and to come up with better diagnostic methods and treatments, which we've benefited from today. And we'll talk about some of that. But first, I want to just put out there a few definitions. I'm going to use the term memory, which really involves two major processes: learning and recall. So we have to get the information into our heads, and we have to be able to retrieve it when we want it. But I also use the term cognition, which involves memory, but other mental skills, like paying attention, reading a map, what we call visual spatial skills, being able to think and reason. Those are all parts of cognition. Now, dementia refers to a memory loss or another cognitive impairment that is so severe that the patient needs help from others, so no longer independent. Alzheimer's disease is the most common cause of dementia. It has a gradual onset and gradual progression, and in the brain we see this buildup of amyloid plaques and tau tangles. Now, one way to conceptualize what occurs in the brain is depicted on this slide, where we have brain health on the vertical axis and age or time on the horizontal axis. And for all of us, there's this gradual decline. And what doctors have done is to demarcate three major points in that decline. First is normal aging, what everybody jokes about and complains about when they can't find their keys. or they can't remember someone's name. This is normal, doesn't seem to disrupt people's lives. If that worsens, then the individual develops what's called mild cognitive impairment. People with MCI, or mild cognitive impairment, are still functionally independent. They can compensate for those memory losses. However, they are at greater risk for dementia. And every year, people with MCI have a 10% risk of developing dementia. And we can follow these different problems with pencil and paper tests from neuropsychological testing or brain scanning tools like PET and MRI. But the clinical assessment is critically important to define whether someone is functionally independent, having MCI or normal aging, or whether they need help from others and they have dementia. Now, if they have dementia, there are many different causes. Even though Alzheimer's disease is the most common cause and accounts for about 60 or 70% of cases, you can see from this long list there are many other causes. And sometimes they are irreversible, like Alzheimer's disease, Lewy body dementia, or frontal temporal dementia. But occasionally there are reversible causes of dementia. There can be a drug toxicity or a thyroid imbalance. So it's very important, if anybody is concerned about their memory or cognitive functioning, that they see the doctor to find out what's going on and get a proper treatment. When they do go to the doctor, there's a fairly standard approach where the doctor will get a comprehensive history, talking to caregivers, because the patient has a memory problem, won't remember all the details. Look at the rate of onset of the illness, whether they're physical illnesses that could be increasing risk for cognitive impairment. The doctor will do a neurologic examination, a physical examination, and then a mental status examination. So the doctor may use standardized tests like the MMSE, or Mini Mental State Exam, or the HAM-D, which is the Hamilton Depression Scale, to see if there's depression that can sometimes look like dementia. We'll do a functional assessment to see if the patient is independent. Laboratory tests involve checking for medical illnesses like anemia or thyroid imbalance or metabolic imbalance to see if that can be contributing to the cognitive deficit. And often there will be a brain scan. Usually a CT or MRI scan is performed to see if there's a tumor or a stroke, or occasionally some illness that could be reversible. Occasionally we do PET scanning that can help us rule in Alzheimer's disease or frontal temporal dementia, which can have implications for the treatment. Sometimes genetic testing is done, and this is relevant to early onset Alzheimer's because there are rare families where Alzheimer's strikes 50% of the relatives. These are called autosomal dominant inheritance patterns, and when somebody comes in and they have that kind of history, we can send the patient to a genetic counselor, and they can get a genetic test to find out if they will get the disease. That's relatively rare. It does happen in a certain percentage of early onset cases and late onset cases. More often, there are genetic risks, and the most common is called ApoE. ApoE comes in 3 different forms. 20% of the population has ApoE4, and this will increase an individual's risk for Alzheimer's, but it's neither necessary nor sufficient to develop the disease. So we don't generally recommend that in clinical settings. It's used more in research. And I put in this slide the TREM2 triple risk for Alzheimer's. It's another risk gene that we're studying, as well as other risk genes. But for now, ApoE seems to be the most prominent or major genetic risk in the population. Now, our approach when somebody comes in is summarized on this slide. As I mentioned, we're all on this downhill slope if we do nothing to protect our brain. If you have a genetic risk, it may be faster than if you don't. And what our goal is to identify people at risk early and to try to intervene early so we can slow down that decline curve. For a variety of reasons, people tend to avoid the doctor, and the doctor is only able to do too little, too late. So I believe, and many of my colleagues believe, that it's going to be much easier to protect a healthy brain than try to repair damage once that damage is extensive. There are other reasons to go to the doctor early, and there are practical consequences of improved diagnostic accuracy, as we see on this slide. An accurate diagnostic approach helps educate the families and reduce caregiver burden. It decreases the likelihood of families shopping from doctor to doctor to try to get a more definitive diagnosis. The idea that an Alzheimer's disease label is bad has been disputed by the systematic research. It's even shown that getting a proper diagnosis improves the caregiver's attitude. And information about the disease will improve quality of life for the patients, for the families, and can delay nursing home placement. Let's talk now about early onset dementia and some of the specific issues and how it differs from late onset. By definition, early onset is when the disease begins before age 65. The cause may be Alzheimer's disease, but just like late onset, there can be many different causes. The Alzheimer's Association estimates that between 220,000 and 640,000 Americans suffer from early onset Alzheimer's disease and other dementias. Families and patients are confronted by specific problems when the disease occurs early in life. One problem is that it's difficult to get an accurate diagnosis. Usually we see dementia in older people, so it's not expected in a younger person. And so the symptoms may be ignored, and the doctor may not think about it. And from the patient and the family's perspective, it can be frustrating to get an accurate diagnosis. When it strikes people early in life, they're still employed, and so they not only lose their job, but the family loses income, and there's an effect on the patient's self-esteem. There's difficulty in obtaining Social Security disability insurance, supplemental security income, as well as other disability payments. With early onset dementia, we see a lack of health insurance and high out-of-pocket expenditures for medical care. People under age 65 generally do not have Medicare, and early onset patients may qualify for benefits, but only after a 2-year waiting period. And even those with health insurance, they're likely to have high out-of-pocket expenditures for premiums, deductibles, co-payments, and other services. High out-of-pocket expenditures are an issue for long-term care. Americans don't get these services as they should, and long-term care services such as adult daycare and respite care, they can be less expensive, but the total costs will add up when they're used consistently over long periods of time. Another issue is the lack of appropriate medical care, residential care, and community services. Most services for patients with dementia are designed for and targeted to older adults. And so many early onset patients are just not comfortable with those services, and they'll tend to avoid them or even refuse to use them. Healthcare, residential care, and community service providers may not know how to treat, provide care for, or communicate with people with early onset dementia, and we don't have training programs to address these problems. When we see dementia in younger people, there's often a wider range of diseases that can cause the problem. And younger dementia patients are more likely to have a rare form of dementia, more likely to have problems with movement, balance, and walking. They're also less likely to have coexisting medical conditions such as heart disease. And they're more likely to be physically fit, which is definitely in their favor. Genetics are more often a factor with early onset than late onset. And if dementia has been inherited, the diagnosis may have implications for siblings and children. And these are important discussions to have with families. Now, if we do nothing to help somebody with dementia, or if somebody is on a placebo, you can see from this slide, things just get worse. Today we have several what we call symptomatic treatments, and you see them advertised on television, direct to consumer these days. You're familiar with them. They're listed here in blue. They don't cure the disease, but they do help with symptoms temporarily. And you see a benefit, but no change in the slope of decline. And if patients go off the medicines too soon, they have a more rapid decline. And this is often an error that families make. they see patients getting a little worse, and so they assume the medicine isn't working and they take them off the medicine. And it's important not to do that, to try to keep patients on medicine longer in those situations. Now, the research currently is focusing on what we call disease-modifying treatments. And these would be medicines that will alter the slope of decline, as you see here. And if you stop the medicine, there'll be a sustained effect. And a way of thinking about this would be thinking of if you had a pneumonia. If you had pneumonia and you took aspirin, that would be a symptomatic treatment. You'd probably feel some temporary relief. You'd have less fever, but it wouldn't cure the disease. You'd have to take a disease-modifying treatment, an antibiotic, to make a difference. Now, despite tremendous efforts to try to identify these disease-modifying treatments, there's been no success as yet. And there have been pursuits at trying to clear those plaques and tangles out of the brain. There have been efforts using anti-inflammatory drugs, cholesterol-lowering drugs, and even insulin treatments, because we know there's a connection between diabetes and risk for Alzheimer's. And those studies are ongoing. Unfortunately, to date, we don't have any major breakthroughs. However, we have learned a lot about healthy lifestyle. And so you see this image of an older person pole vaulting. I would like to be doing this when I'm 95, but I probably won't be doing it because I've never pole vaulted in my life. But that's okay, because the research also tells us that genetics and having that pole vaulting gene is not the whole story. In fact, for the average individual, whether it's early onset or late onset, non-genetic factors tend to be more important than genetic factors. And I'm just going to briefly review some of those factors in the next few minutes. Physical conditioning, mental stimulation, and cognitive training, stress management, and proper nutrition. And I like to begin with physical activity because I think we have the most compelling scientific evidence in this area. So anything you can do to get your heart to pump oxygen and nutrients to your brain cells, that's going to be good. Whether you walk, run, swim, move your arms around, that's going to promote brain health. Not only does it get oxygen and nutrients to your brain cells, your body produces chemicals like brain-derived neurotrophic factor, or BDNF, that cause your brain cells to sprout branches so they can communicate more effectively. And you all know about runner's high, which is from endorphins, so that lifts your mood as a result of the exercise. And you don't have to become a triathlete. Just walking briskly 20 minutes each day has been associated with a lower risk for Alzheimer's. Another area that's important is mental stimulation. The idea of doing puzzles, pursuing education, that has been associated with better brain health, as well as specific memory training techniques that have been shown from our studies and those of other sites that learning these memory techniques can compensate for mild age-related memory loss, that so-called normal aging. And if you keep using these methods, you can have long-term sustained benefits. Now, at our UCLA Longevity Center, we have these memory training classes. We teach them locally here in Southern California. We've licensed them all over the country, and our latest license actually has crossed the border to Canada. And in these courses, people can learn these kinds of memory training techniques, and we have some courses that branch beyond memory training and actually teach people healthy lifestyle approaches. One of those approaches is stress management. We know that chronic stress actually shrinks some of the memory centers of the brain. And on the positive side, stress management methods can actually counteract that effect. Helen Lavretsky here at UCLA has done some elegant studies, and you see some of the brain scans here, where she finds just 10 minutes of meditation each day literally rewires the brain and improves mood as well as cognitive ability and even measures of longevity. Nutrition is tremendously important. One of the most important things is weight management. We know that midlife obesity increases the risks of late-life dementia. So trying to find your optimal body weight will protect your brain. And the kinds of foods you eat are important as well. People tend to eat too much omega-6 fat from red meat products, from whole milk products, and not enough omega-3 fat from fish, nuts, and flaxseed, which is anti-inflammatory, so protects the brain from excess inflammation. The average person doesn't ingest enough servings of fresh fruits and vegetables, which are antioxidant and protect the brain against oxidative stress associated with aging. And finally, we tend to ingest too much processed foods, refined sugars, which can increase our risk for type 2 diabetes. And if you develop diabetes, that can double your risk for Alzheimer's. We've been studying these healthy lifestyle approaches here locally at UCLA in collaboration with other institutions such as Erickson Living, and we find that within 2 weeks, after 6 weeks, that people enjoy improved memory performance, and it even creates benefits in their brain, particularly the frontal lobe of the brain. When we do brain PET scans, we find higher efficiency in certain important memory regions of the brain. Now, we know there's a huge caregiver burden for Alzheimer's disease, and I'm sure many of you who are watching today are caregivers, and you know firsthand how challenging this is. And I'm just citing this particular study because it targeted early onset patients and caregivers of those patients, and it was a systematic review of the impact of early onset dementia on informal caregivers. And the results showed that caregivers of early onset patients experienced, not surprisingly, high levels of burden, stress, and depression. They also had problems with relationships, family conflicts, problems with employment, financial difficulties, and problems concerning diagnosis, as I discussed earlier. And the authors of this review concluded that caregivers of early onset patients experience high levels of psychological suffering and specific problems related to their phase in life. Other issues to consider that affect people early in life, of course, are finances because of loss of livelihood. Driving is a huge issue. It's one of the most traumatic experiences for older adults or middle-aged adults who develop dementia, is having to lose their driver's license. And so this involves lots of conversations with healthcare professionals, with the family members, as well as conversations about genetic risk. And another issue is finding age-appropriate services, the right kind of family doctor, specialists in geriatric psychiatry, in neurology, and also finding resources in the community, such as the Alzheimer's Association and other support organizations and advocacy groups to help. Now, I want to cite just one program that we've developed through our UCLA Longevity Center. We call it Memory Care. And this is a program, a very popular, growing program that we have. It involves weekly meetings that are targeted for patients with relatively mild dementia and their caregivers. So to enter the program, we need a caregiver and a patient. And all sessions will feature evidence-based exercises, and they're led by doctoral level trainers, faculty, and staff. And so for each of these weekly sessions, there are 3 groups, and they're 60 minutes each. The first group goes over strategies to lower stress and stimulate the mind as well as the body. The second goes over practical techniques for enhancing memory performance, some of those memory training methods that I mentioned earlier. And the last hour, the caregivers and the patients break up into 2 groups. The caregivers benefit from a support group where they can talk about their issues, and the patients go have a reminiscence group, which is very helpful to stimulate their minds. And I bring up this program in particular because we're expanding the program this year, and we're developing a group that is specific for early onset patients and their caregivers. I mentioned earlier how it can be a challenge for early onset patients because there are not services available for their age group. And now we're going to have a group that is targeted just for this age group. And we thank the Fran and Ray Stark Foundation for allowing us to develop and to hold these early onset groups and actually in perpetuity through an endowment to UCLA. If you or a loved one is interested in finding out more about our UCLA Memory Care program, please call us at 310-794-0680 or email us online at longevity@mednet.ucla.edu, or you can just Google UCLA Longevity Center and you'll find out information about memory care. So to summarize, current diagnostic and treatment strategies do improve function and quality of life. It's important to get started early because the sooner you have a diagnosis, the more we can help. There's a lot of research on drugs and biomarkers, and I am optimistic that in the near future we're going to have even more to offer our families. But as we're waiting for future studies, there's a lot all of us can do. We can pursue early detection of dementia to optimize treatments. All of us can live healthy lifestyles to improve our mental function today and stave off symptoms in the future. And we can take advantage of some of the age-specific services to meet the needs of younger patients. For more information, here's our website, or several of our websites, and I want to thank you all for your attention today. Again, you can tweet if you have questions, hashtag UCLAMDChat. And while we're waiting to see if those tweets are coming in, I will just stand here and improvise. I want to just make a comment on the emotional impact of this disease, how difficult it is for families. And I see this every day in my practice. I see it among family members and friends. And the stories are really very dramatic and traumatic. And so it's important not to be isolated, to reach out to others, to try to get help because there is help available, and to be an advocate of the help. We really don't get enough funding for Alzheimer's disease to do the research the way we should be, so that's important. And also, if you have a family member with the disease, think about clinical trials or volunteering for a research project, which will help us move forward. So I think, do we have some tweets I could take a look at? Okay, great. How do scientists measure benefits of mind-body practices for dementia? So the mind-body practices, generally, the research has not been targeted at patients with dementia. It's really been targeted more towards people at risk for dementia. And so some of the studies have found, for example, that people who are prone to stress have a higher rate of developing dementia. Or the studies I show that Dr. Lavretsky did, when there are interventions, meditation, Tai Chi, they can systematically measure before and after the intervention whether there's an improvement in cognitive function. And all these studies, those kinds of intervention studies, are done with control groups that don't receive the intervention. How can I best prevent dementia if my grandma has it? Whether your grandma has it or you don't have a family history, the best thing that people can do is to live a healthy lifestyle and pretty much follow some of the guidelines that I mentioned just a moment ago, where you stay mentally active, physically active, try to manage stress as best you can, eat a healthy diet, and there are other strategies. Stay socially connected. Loners don't do well. And I see this very much in patients with MCI or dementia patients where they get isolated and they're worse. And when they're with family and friends, they perk up and they do better. So try not to isolate and stay socially connected. If you want more systematic approaches to this, please visit us at the UCLA Longevity Center. We have many programs. I've written many books on this. You can find out about that on the internet. So there's a lot of resources out there and programs from other agencies that are looking more and more towards trying to protect brain health through lifestyle strategies. Can doctors recommend memory training programs, and is it covered by insurance? So certainly doctors can recommend it. Right now, it's a little tricky to get coverage. There is something called neurocognitive rehab in specific situations But for most of the programs we have, they are educational programs. Some are very modestly priced, and so if finances are an issue, you can certainly contact our center. We can refer you to places where it's inexpensive to get the help you're looking for, and even and others can be a bit more expensive. So I think those are the end. Do we get any more tweets? I think that's where we are at this point. I want to again thank all of you for paying attention to this information. And please feel free to get back to us anytime at UCLA. We have many different programs here, not just in my department in psychiatry, but neurology, geriatric medicine, that are designed to help the many people who are suffering from this devastating illness. Just remember, help is out there and we want to be helpful. Thank you.